All right, last topic we're going into for Unit 3 is endocrine. But first, you guys have met Oswald and Jojo, and now you get to meet my favorites, which are Jack and Litten. I'm definitely a cat person over a dog person. Don't get me wrong, I love dogs, but cats are the best. So, especially ginger cats like Jack here. He's my boy. Litten is feisty. She's like a calico tortie mix, and she's just pure spite. I mean, she loves me. I'm her mom, but anybody else, she's not super fond of, as opposed to Jack, who loves anybody and everybody. All right, back to endocrine. So we're going to get into thyroid disorders and parathyroid disorders, and then we're going to start talking a little bit about corticosteroid therapy. First, on to thyroid dysfunction. So hypo or hyperthyroid are the big ones. So if it's kind of on a continuum here. So euthyroid means that your thyroid's normal. And then it can start to get hypothyroid. And then it can get very severe, which is this myxedema coma. Which can be, this is like the medical emergency side of hypothyroidism. And then on the other side of the spectrum is hyperthyroid. So the thyroid's working a bit too much. And the emergency side of that is this thyroid toxicosis or thyroid storm. These patients are definitely in the ICU, and we're monitoring them for a lot of complications, including dysrhythmias. So there's primary and secondary hypothyroidism. Primary is when there is an issue in the thyroid itself. Secondary is generally from the pituitary gland, which is what kind of encourages the thyroid to make thyroid hormone. So in primary, you have low thyroid hormone, but you have this high thyroid stimulating hormone, and that's what's coming from the pituitary gland. So the pituitary gland recognizes that we have low thyroid, and it's like, hey, make more, make more. So it sends out this increasing levels of TSH, but since it's primary and the thyroid is the issue, it's not going to be able to make more thyroid hormone. As opposed to secondary hypothyroidism, that's when there's an issue with the pituitary gland. And so the pituitary gland isn't sending out thyroid stimulating hormone, and so the thyroid is not being stimulated to make thyroid hormone. So hypothyroidism is a hypoactive thyroid. Table 49.6 gives a list of hyper versus hypothyroidism symptoms. So I would definitely be familiar with that. So common causes of hypothyroidism. In the US, it's usually this atrophy of the thyroid gland. Can come from Graves' disease or a thyroiditis. That's our most common in the US. Worldwide, hypothyroidism is generally caused by this iodine deficiency, but we tend to not have that issue as much in the US, so it's more these hyperthyroid issues that eventually beat up the thyroid so much that it goes hypothyroid. The other issue can be a thyroidectomy. So if the thyroid's been removed or part of the thyroid's been removed, then it can become hypothyroid. What is important to know about hypothyroidism is that many symptoms in older adults can be confused with normal aging. And so we'll get into some of those symptoms here in the next slide, but like weight gain, constipation, fatigue, cold intolerance. I mean, these are symptoms that you generally just associate with getting older, but they could have an underlying thyroid issue. And so these are some of the symptoms of hypothyroidism. And so I love this image because it basically describes hypothyroid, right? We're slow. Everything has become very slow. So we have a slow metabolic rate, so we don't really tolerate activity very well. We're tired, we gain weight, we're not moving, so we get constipated. We have a decreased cardiac output and a lower heart rate. And then we're very intolerant to cold. And then a goiter is this swelling that you can get on the thyroid gland itself. And so you see that on the patient's neck. This can be associated with hyperthyroidism as well. And then the other thing is depression. So again, you're just very slow, very sad, very... The big thing we worry about when it comes to goiters for both hypo and hyperthyroidism is it's right on the thyroid gland. And so if we go back to my first image here, this is our thyroid gland. And what is it surrounding? What is this big important tube right here? It's your trachea. So when we start talking about some of the thyroid surgeries and such like that, we're really going to be worried about airway and airway compromise. So hypothyroid is lifelong medication. So it's not something that's just going to get better. The thyroid's no longer working, and so we need medication that gives that thyroid hormone. It requires frequent lab work until we get the dosage at a good level. So every 4 to 6 weeks, the patients are coming in to get their lab tests drawn. So they get their TSH and their T4 levels drawn to see where their levels are at. And we may need to, decrease the dose. We may need to increase it. It really just depends. It can take up to 2 months for full effect of the medication. So we might need to reinforce teaching. This is the one time where a list is encouraged, and that's because these patients, you saw some of those symptoms, right? They've got brain fog, they're slow, they're depressed. And so when they're hypothyroid and it's going to take 2 months to get them up to a normal thyroid functioning level, they might need repeated instructions or written instructions that they can reference later on. The other thing we want to teach our patients on are signs and symptoms of an overdose, which would be signs and symptoms of hyperthyroidism, which we're going to get into next. So hyperthyroid is the exact opposite of hypothyroid. So very high metabolic rate. We're just running, very active. So they're sweaty, restless and irritable. They get weight loss from this high metabolic rate. The diarrhea, because their GI system is so irritated. They can have palpitations or dysrhythmias. They become intolerant to heat because, again, that metabolic rate is just keeping them so hot to begin with. They also get this exophthalmos, which is a fun way of saying that there's edema to the orbital tissues, and the ocular muscles can start pushing the eyeballs outwards. And so because we get this edema to that tissue, what can help is kind of keeping the patient a little bit elevated, sitting up in bed a little bit, and help that edema drain. These guys are on huge high-calorie diets. Like we're talking 6 meals a day with snacks, 4,000 to 5,000 calories a day. Because even though they might not be very active, their body is. Their body is essentially running a marathon this entire time. So the most common cause of hyperthyroidism is what's known as Graves' disease. It's an autoimmune disorder, and so it can be present with other autoimmune disorders. It can also be from an irritation or thyroiditis, so irritation, inflammation to the thyroid, too much iodine, pituitary gland tumors, or cancer can also cause hypothyroidism. Hyperthyroidism. So Graves' disease is an autoimmune disease, and it's these antibodies bind to the TSH receptors, which stimulates the secretion of the thyroid hormone. And so we're getting this T3, T4 secretion. It eventually can destroy the thyroid tissue, like I mentioned earlier. And as the tissue gets destroyed, that leads to hypothyroidism. And so treatment for hyperthyroidism is this anti-thyroid medication, Unlike hypothyroid, where they're on it for life, this therapy is generally for about 6 to 18 months, and then we check to see if the patient goes into remission. Again, this medication can take up to 2 months for full effect as well. And then we just see how they do with the medication. And like I said, 20 to 40% of patients will just go into remission and they won't need any medications. Iodine is another treatment that they'll use. It's not an effective long-term treatment, but it is good for pre-surgical prep. Beta blockers are used to just treat the symptoms, right? So they calm the sympathetic response, that whole tachycardia, irritable, shaky aspect. They help calm the patient down with those symptoms. Radioactive iodine therapy is the treatment of choice. This damages or destroys thyroid tissue. So a lot of the patients can become hypothyroid. It's about 80% of patients will develop hypothyroid. The big thing is we do need to watch. Pregnant patients can't have this because, again, it's radioactive. And then these patients can have radioactive body secretions. And so just remember, when it comes to radioactive body secretions or radioactive precautions, we need to be aware of these patients. So this is where they're going to want to flush 2 or 3 times after going to the bathroom. They need to avoid pregnant people and children. They need to stay 6 feet away from people, launder their clothes and bedding separately, that sort of thing. And then the other treatment that we can do for hyperthyroidism is surgery. So this is usually if they have a goiter or other mass on the thyroid, or if they're unresponsive to any of the medications that we've tried. Just giving you a moment to read. So what are our priority interventions on a post-op thyroidectomy patient? Remember, we were talking about this image here, right? So it's definitely airway. Anytime we have surgery around the airway, we're watching for swelling of that area, bleeding around there. And one of the first indicators that you can get that swelling is happening is a change in voice. And so if you kind of pinch your airway, you can kind of get this different sound to your voice. So those are the big things we're watching for our patient. If there is a change in voice, we are scared that they're going to lose their airway or any difficulty speaking or swallowing. The parathyroid are these 4 tiny little button-sized glands on the posterior aspect of the thyroid. They secrete parathyroid hormone, which, if you guys might vaguely remember from A&P, helps increase our calcium and decrease our phosphate. It also activates vitamin D. PTH secretion is regulated by negative feedback. So when the body senses low calcium levels, it stimulates the secretion of parathyroid hormone, and parathyroid hormone will then start to take calcium from the bones to increase the calcium in the serum. As opposed to if the body is sensing high levels of calcium, then the secretion of parathyroid hormone or PTH is going to fall. So hyperparathyroidism is when we have too much of that parathyroid hormone. Again, primary is usually from a tumor of the parathyroid gland. Secondary means it's not the parathyroid gland itself that's having the issue. It's generally a disorder that can cause hypocalcemia. And so then the body starts secreting more parathyroid hormone as a compensatory mechanism. So hypocalcemia disorders would be like vitamin D deficiencies, GI malabsorption orders, chronic kidney disease decreases our calcium level, and then also hyperphosphatemia. So because calcium and phosphate have that kind of opposite effect, if we have high phosphate, then we're going to have low calcium. So the table 49.15 gives hyper and hypoparathyroid symptoms. So generally in hyperparathyroidism, we have hypercalcemia because we're pulling all that calcium from the bones. And then we have hypophosphatemia because again, we've bound all that phosphate out of the system. Some of the symptoms are constipation, loss of appetite, fatigue, emotional disorders, muscle weakness, osteoporosis because we're pulling all that calcium away, kidney stones because they've got a high calcium, and dysrhythmias. The big treatment is to try and flush some of this calcium out. So we give lots and lots of fluids and diuretics to try and flush that calcium through the urine. We can give phosphate, but this is only when the phosphate levels are already low, and it helps bind the calcium. Or the other treatment option is surgical, so we'll remove some of the parathyroid glands. And so this one's a little different, right? So, still post-op parathyroidectomy, we are going to be worried about airway. But if they're experiencing symptoms of tetany, that means they've had a sudden decrease in calcium levels, which that can happen if we've removed the parathyroid gland or some of the parathyroid glands. So symptoms of this is going to be like tingling in the hands and around the mouth. They can have muscular spasms and laryngospasms. So again, we are worried about airway, but the big thing that's causing that airway issue is the low calcium. So our treatment is going to be giving IV calcium gluconate. So it's usually a slow IV push. So over about 10 minutes or so, we'll give that calcium gluconate. And then we'll start to worry about the airway, right? So the first treatment, the first priority is solving the problem, and the problem's hypocalcemia. And so we'll give the calcium first, and then we may need to do airway interventions as well. Here are some of your signs and symptoms of hypocalcemia, other than what we just talked about. So they have I can't pronounce those, but you have your signs where you get this kind of spasm of the face when you're touching. And then they can start getting these carpopedal spasms, especially if you do like a blood pressure on the arm. You can see this in your patients. As that blood pressure cuff starts to squeeze up, they start to get this spasm in the hand. So hypoparathyroidism is kind of what we just talked about with when they had surgery on the parathyroid gland. So we have low parathyroid hormone levels, which lead to low calcium. This is a more rare condition. The most common cause is usually an accidental removal of the parathyroid glands or damage to the parathyroid glands during a thyroidectomy. Treatment is the same as post-op parathyroid patients. We may be able to be a little less aggressive with this because it might not be as an acute of an exacerbation, so they can have just calcium supplements to keep their calcium levels up. The other thing that can help with these patients is rebreathing. And so like when you give them a paper bag to breathe into, they're breathing back carbon dioxide levels. So when they breathe back carbon dioxide levels, it creates an acidic environment which ionizes more calcium in the body. So it's kind of an acute thing that your patients can do, and this can be very helpful if they are having those carpopedal spasms, is you can give them a bag to rebreathe into. All right, Cushing's syndrome is a chronic exposure to excess corticosteroids. It could be from medication, or it could be that their pituitary adenoma has been secreting ACTH. And so table 49.16 lists some of the clinical manifestations of Cushing's syndrome. Some of those are weight gain or this centripetal obesity, moon face, and buffalo hump. Again, very, not going to make your patients have any sort of embarrassment over those names. They can get hyperglycemic from insulin resistance from the cortisol, muscle wasting and weakness, loss of collagen, so thin skin and easy bruising, delayed wound healing. They retain sodium and water, become hypokalemic and hypertensive. And so if patients get Cushing syndrome from long-term corticosteroid use, then we may need to reduce their dose or taper it down. We can also, if it was from an adrenal tumor or hyperplasia, we can use surgery to treat that. But the most common cause of Cushing syndrome is this long-term corticosteroid use. And so we do a gradual discontinuation. They can reduce the dose, or they can do like alternate day dosing to help with this syndrome. The big thing that you need to be aware of, though, when it comes to corticosteroid treatment is we can't stop it immediately. So when patients are on corticosteroids, the adrenal glands kind of stop working because they're like, oh, there's steroids in the body, like I don't need to make any. And so if we stop that medication, the adrenal glands have stopped too. And you can get this severe drop in blood pressure and blood glucose, and it's lethal. And so that's why steroids have a gradual tapering if it's a long-term treatment. So generally, if the treatment's been over like 1 to 2 weeks, that's when you need to at least have a tapering and not just stop it all of a sudden. And so that's a big education piece for our patients too, that if they're on long-term corticosteroids, they can't just stop the treatment. All right, that's all I've got for endocrine. Please let me know if you have any questions and continue to have fun at clinical, guys.